It is indeed my pleasure to be here today. I have been in Finland a couple of times before, and the reason for that is that my wife's ancestry goes back to Finland. We shook the family tree rather hard and have found 25 relatives that we visited in the last few days, and it's been quite a pleasure, relatives between here and Rovaniemi. So that it is indeed a pleasure to be here for that purpose. But I've also known that Finland has been very, very advanced in the electronic record, partly because this has been adopted from the VA system back in the 80s and 90s. And there is probably a higher use of, higher physician use of an electronic record, albeit a different record from place to place than many other countries. So I think actually the first step, which is to get the doctors to use the record, is largely taken, and getting the connectivity that you're now talking about is certainly something that we all strive for. The VA is 1,300 sites, 157 medical centers, so it's quite large. As importantly as that, the affiliation is with many medical school, about 80,000 trainees each year. So 70% of the MDs in our system who are up and coming have been exposed to the record, as you will see in our hospital. Our hospital is listed as paperless. It is also filmless. And it is receiving a large bit of good news. This was from the Institute of Medicine, VA's integrated health information system, including its framework for using performance measures to improve quality, is considered one of the best in the nation. Electronic health record in the Department of Veterans Affairs is the best in the United States, absolutely the best at large scale, and probably the best in the world. Now this will all change. There are a whole lot of new systems coming up, and this is last year or 2 years ago. I'm sure will change as time goes on. But I will discuss the electronic health record as we have developed it in the VA, the text and imaging aspect. The imaging aspect was actually alpha tested at our site at the Washington VA where you visited earlier. We have adopted a personal health record which actually discloses everything in the electronic health record to the individual on a website and allows him to put in personal information such as weights, which you will see. And I will discuss the remote data and image views that have been very, very instrumental in pulling our system of 153 hospitals and many, many clinics all together so that each individual can see the record from all of these sites at once. We have a PDA, a small application, which we use for our barcode medication administration. And as much as anything else that has helped our patients has been the adoption of performance measures, which have reminders embedded in the electronic record, and we have been able to achieve rather startling results. We can retrieve the data, this is a database, and manage in very interesting ways, which I will also discuss. The next 21 slides are in a demonstration, which I will put live on the system here. Adjust it just a bit. And as you can see, this is the cover sheet. And the first slide is also the cover sheet. Can we have this displayed? Maybe. Aha, good. We're in business. So on the left, you will see the dynamic record as we see it in our hospitals. As a matter of fact, in my computer, I have simply downloaded the electronic record as it exists in our hospital with a fair number of patients, not nearly as many, needless to say, as exists in the record at the hospital, but with fairly advanced software. And you can see on the cover sheet we have the active problems, the active medications, the vital signs, which are quite important, any allergies the patient might have, and the clinical reminders. If I go to the next tab, which is the problems, you can see that I can pull up a list of any problems, making them active or inactive, by simply typing in coronary and clicking on search. I immediately pick up this list, which is complete with ICD-9 codes. Now that's very important because as we make our problem list connected to ICD-9 codes, that can be used for our encounters and our super bill. If I go to the next tab, which is orders, you can see that I can order any inpatient medication or outpatient medication, any of the lab tests. If I click on imaging, I can order general radiology, chest, PA, and lateral, change the patient from wheelchair bound to ambulatory, and accept the order. Once I've done that, that is in our x-ray department, and the patient then arrives and can have the x-ray immediately taken. If I move to the Notes tab, on the bottom, you now see that I could bring up all of the notes in a list. I can actually order them simply by clicking by date or author or the title of the note and see the note in the lower panel. And I can create a new note by asking for that as a cardiology note, since I am a cardiologist. And what comes up is several pieces of information already present in the record. As a matter of fact, in the more robust situation, we would see all his echocardiograms, all of his exercise tests, and several lab tests that are pertinent for each visit. The reminders, as I mentioned, are extremely valuable, and I can show you some that are not due for this patient, but if I clicked simply on hypertension, this would give me the last blood pressure, which was okay. It would automatically be called due if it was over 140. I could then put in my own blood pressure, which goes into the vital signs area, and then I can click various items like this box, which then has this piece of information. This area now becomes part of the note that I'm writing, so I've written that note rather fast. I can go down and click exercise as a needed item, and that too becomes part of the note. And I obviously can also click nutrition, which can become part of the note as well, particularly noting several specific areas of low fat or of sodium. All of these now become part of the record. Now the reason why that's good to have them very clear and specific and fast is that the patient now gets to see his record in the personal health record, and he can see these requests that I have made of him. And the answer to that question is yes, I do want to cancel. So these are the reminders on the slides, and then I will move to the encounter, and I can put the type of visit and the diagnosis I simply get from the cover sheet, and I have the ICD-9 codes linked with that. Now, one of the most important parts of the record, I believe, since in part we developed it at our hospital and we were the alpha site, is the imaging aspect. And it's linked very tightly. Now you see all of the images, the retinal exam, the x-rays, the echocardiogram. I can go down and click on the x-ray. And the nice thing about this is that I have automatic leveling. For instance, if I wanted to see the wire that's coming across up here, I can put a little note here and be able to see it. And I can't see anything down in the heart. But if I put that on the heart, I actually can see the wire as it comes across. Wire as it comes across, and its tip, as you see down below. So I can follow this very nicely through the record. I can come back and see the X-ray as it previously existed. I also can go to the electrocardiograms, and you can see that I can make it the full screen if I wish. I can go to other electrocardiograms. There are quite a few for this particular patient. And this particular one shows the patient to be in ventricular tachycardia. The ventricular tachycardia for this patient was very important since it is somewhat slow. He has an implantable defibrillator, as we saw, but the defibrillator cannot address this because it's too slow. It would be shocking against his sinus rhythm. So we actually put a wire into this patient's heart, found this location, and put the radiofrequency current to ablate it. And he no longer has this particular slow VT. If I go to the record once again and back to the notes, one can notice on the sign notes that the patient has several icons next to the notes. If I go down one level and click here, you notice that some images came up at the bottom. If I simply click on the image, I can see actually a moving picture image representing the patient's coronary artery. If I put it in repeat mode, we can see it repeatedly. I can see it in different views. I can see the other coronary artery. If we go back to the original picture, I can stop it at any time and bring it frame by frame or a little faster and actually enlarge it if I need to. Every now and then patients are a little resistant to having these things open, but if you show them how narrow it is, they often say, well, please, take care of that. And as a matter of fact, if we then look at the future, there is a balloon in the heart, which is now opened up to the vessel quite nicely. I can once again stop it and slow it down, going back. The vessel is quite nicely opened, and we'll go on from there. If I bring up another patient, simply by, well, first I will delete the progress note that I've been, it won't allow me to delete that note because I've signed it, but it will allow me to delete this new note that I've written. These notes can be deleted only if you have not signed it. Once you've signed it, it becomes part of the permanent record. If I didn't do that as I went on to the next patient, it would remind me to sign that note, which I don't want to do today. If I go to the next patient, I'll show you how labs can be brought up with the worksheet. I'll pick off hemoglobin in this instance and ask for all the results. The worksheet is fine, but much better is the graphic record. Notice how the hemoglobin has suddenly and precipitously fallen on several occasions. That means the patient has been bleeding. As a matter of fact, if I go into his endoscopy, which can be put on the images as well, and I can make them bigger, you can see that he has diverticuli on these two pictures, and as a matter of fact, fresh red blood coming down those, to the scope. So this obviously documents the fact that he is bleeding from his lower colon. That can be additionally taken care of by the X-ray, which I can zoom, pan over, change the level, and I see that this vessel now is giving off this little pool of blood. If I wanted to see the inner part, I would have to level it again, and as a matter of fact, if I wanted to see the aorta, I would have to re-level this as well. We have gotten so used to using these digital tools for looking at X-rays in our hospital that we will not look at X-rays without the digital system. We will not look at film, and as a matter of fact, that's good because they don't provide any film for us to see. I will go to the next patient. And we'll take a look at his labs on his worksheet. And in this instance, I'll pick off several of these categories and say OK, say that I want all the results. Now I've got quite a robust graphic sheet, but I will go to the sodium, which looks very low when he first came in, and then go to other areas like the albumin, which was also quite low, and the white count. This man was paralyzed, and the high level of his white count was also noted, and it was seen that his paralysis had started in one leg and then had moved to the other and then involved the abdomen and was quite severe. They were ready to send him to a rehab hospital. He'd been in the other hospital for 2 months. We took him over to our place, happened to pull a Lyme disease titer on him. It was positive, so he has the deer tick disease. We gave ceftriaxone to him, and his paralysis recovered within a few months. If I look at his discharge summary, you can see that they are fairly robust as well. And as a matter of fact, most of these discharge summaries now are being entered by the doctors. We can put the medications in automatically, but the text is often just typed in by the physician at our place at this moment in time. If I go to the cover sheet, you can see that his weight can be graphed for all results again. You can see how low it was when he first came in our hospital. Then we got a different problem out here. If I wanted to look at it, I can zoom in on it. This is the weights as they appear. I can zoom in on it. Excuse me. Once I've checked off zoom, I can zoom in on it. Now you can see that I see a lot of detail. He's now getting too heavy. Whenever we get up to 170, he would be markedly short of breath and in heart failure. He had a left pleural effusion at this time, which we tapped, greatly reducing his weight. And then it came up real fast. He tapped again, and it came up much slower because we changed his Lasix dose to 80 milligrams instead of 40. He gradually, over time, rose. At this point, we changed his dose once again to 120 and brought him back down and then back to 80 and let him drift back up. Now, we can be very secure about how his weight's going because these are being measured every day in his home. And he gets on a scale. It's a digital scale. It passes the information to a computer that then passes to our server and is put into his vital signs in a chronological way. We see the vital signs like here, done in the hospital, vital signs done in the clinic, vital signs done in the intensive care unit, and vital signs at home, all in one chronological graph, which makes it very easy to keep him out of the hospital if we're tracking this. Indeed, there is a trigger point, which if he rises to that trigger point, a note automatically gets sent to the physician. He can call up the patient, change his Lasix dose, and keep him from coming back in these kind of ways. You can see that the patient has a fusion on the left side here, which I can bring up. And interestingly enough, I had remembered and can easily document that an infusion on the right side as well. And if I just right-click and open it into the second window, I can compare the two. So he has a left and a right pleural effusion. I asked the man how he slept at night. He said, "I sleep on my left side." I said, "Do you sleep on your left side all the time?" He said, "No, I used to sleep on my right side." And ordinarily, this film would be worked up for a tumor of this side, but having known it to be one-sided twice, that was not going to be the case. It was probably his heart failure in both instances because this one went away when we gave him Lasix, and I suspected this one would also. And I said, "Well, why did you change your sleeping position?" And he says, "Well, doctor, you remember." And as a matter of fact, he fractured his hip on the right side. And of course, we, like good doctors, fixed it, pinned his hip. So he's now up walking again. He wasn't walking because of paralysis, then he wasn't walking because of a fractured hip, and now he's walking once again and doing very well. The question is, why is he in the heart failure? And one of the problems is the electrocardiogram, which you can now, I'll actually enlarge that. I can pull up that electrocardiogram. I can actually pull up, I'll pull it up again. I can pull up the next one with a control click. And I'll pull up the last one again with the control click. As long as I click these individually, I can actually see them all, and I can scroll them all at one time. As a matter of fact, in comparing the left bundle branch block he had in the oldest of his ECGs, it got a little wider. If I wanted that in a quantitative way, I could actually just go back up to the readings, and it's 0.154 going to 0.162, going to 0.174. That's the reason for his heart failure. And if I wanted to see the heart in action to see if that's the case, he did have an MRI. Which now can be seen in motion. And you can see that the septum is moving in the wrong direction. It moves over towards the right. He's got a nice squeeze out here, but not on the septum, and that's why, in part, he's in a heart failure in addition to the hypertension he has. If I wanted to see his other films, you could see that this is the blood going in and the blood going out. And I could see four-chamber image as well. So this makes it very easy to see every film the patient has, every piece of information, all on the record as you're seeing the patient. So we'll move on to the slides. You can see this is a very valuable piece of information, and the physicians now are very dedicated to it. If we take it away for even a short period of time, we get a lot of hollering, so there's no problem once they get used to using the record at this level of creating a good reception. The remote view is extremely valuable. We have linked up all of the systems. And there's a button which I failed to show you, but up on the upper right-hand side, when it's blue, that means there's information at some other hospital. We have a master patient index that lets us know that there is that information. And we have a Vista Web that also brings in all of the patient-specific data from all of the hospitals to be seen. The remote ECG view is beautiful in that if we map the Muse to our server at the other hospitals, automatically the ECGs from all the other hospitals are seen chronologically with the ones we're looking at. The remote image view we alpha tested in April of this year at our place, and now it's being distributed throughout the VA system as of this month. All x-rays, scanned images, PDF files, anything, the endoscopies, all the things that are in the image file can be seen for all of the hospitals. And then you could actually get privilege to sign on with remote sites. This is the Vista Web, which would be seen if we just clicked in the tools bar and brought it up. It brings up the patient. I can then click and bring up all of his notes or all of his radiology reports. The future is that we will have a health data repository. It's already started. Data and notes from all VA visits will be integrated chronologically and be in good operation by the first of this year. And it will be on a Java platform, so we're moving away from the MUMPS platform that we're currently on, but the functionality will be preserved. The electronic health record for the patient includes demographics, vital signs, prescriptions, progress notes, discharge summaries, all the things that are in the regular record, and this is the cover sheet that the patient sees. I'll enlarge the ability to see his own metrics is a particularly important thing, which I will go into. Blood pressure, blood sugar, cholesterol, weight, heart rate are all available. This is the reminder the patient sees, and if we clicked on body mass index in the lower portion, you can see that he gets a message saying that his body mass index is higher than 27. As a matter of fact, it was calculated to be 34.9. So he can actually start getting this sort of information and comparing himself with others. If he clicks on My Healthy Log at the bottom, the patient will be able to see his blood pressure, blood sugar, cholesterol, heart rate, or weight. If I click on weight, he gets a nice graphic representation. And notice how nicely this patient went from 272 in the clinic, where I saw him, on down. As a matter of fact, I brought him over to My Healthy Vet on a website right in the clinic to start him, because he hadn't started it before. And I told him I might show this to big audiences. I said nationwide, but internationally is okay too, I'm sure. At any rate, I'm sure that was incentive for him to continue to lose his weight, and maybe a good way to get people to lose weight if I could sign them all up this way and show them to all of you. But he has done very well. In addition, his blood pressure was 170 over 117, very high, and we were worried about it, but I put him immediately on that system as well, and I could check from my home his measurements through that weekend. It was a long weekend. And then we changed his medication, and now he is, as you see on the right-hand side of the screen, below normal, I mean, in the normal range, and very, very good result. So he's now lost a lot of weight and also gained control of his blood pressure. This is the same gentleman I just showed you. Here's a different patient, and in this patient you can see in the early going, I don't think that works. In the early going, the patient has these peaks of blood pressure, and quite frequently, and then they become a little less frequent. When the patient is monitoring his pressure, he sees it's up, remembers that he forgot his medications, and doesn't forget for the next few days, and remembers he forgot again, or that he took too much salt, but he is modifying his own lifestyle in relationship to the blood pressures that we all wish we could take much more frequently than the every 2 months or 3 months visit that we commonly do in a busy clinic situation. So he can see them. If they get too high, they reach the trigger point, and we are notified, and we can then act just in time before he stays at a very high pressure for a very long period of time. We use a PDA, which is a handheld unit that can see the CPRS system, the cover sheet, and the notes. We also can use that same handheld for barcode medication administration. We barcode the patient, barcode every drug in our hospital, extreme advance in safety there. We can also take vital signs with it. We can collect lab specimens with it, and especially blood transfusions. And as a matter of fact, now the ECGs are barcoded so that you barcode the patient, and that puts the man's name in for the ECG identification and makes it quite accurate. This is an example of the medication administration cover sheet, first one, and then the other that's used with this handheld device. In organizing this situation, we developed an IRM steering committee. The director needs to be totally committed. In a hospital trying to do this, if the director is not committed, you are not going to make it. And that's what I told my director when he asked how to do it. And I just said, I've seen it before, and if he's not there and with us, we're not going to get this job done. But he is there. Sandy Garfunkel is his name, and he is very dedicated to this principle of the computerized record. And since he arrived in 1995, we've been going very strong at this. The IRM chief, clinicians with the computer expertise, probably even more important, clinicians with high use but little computer expertise. Once they get sold on the idea, they will tell their friends, and the system goes. And when do you declare victory? One day in our meeting, we said, when can we stop pulling charts? And the heavy user, not too terribly sophisticated computer guy said, I never look at a paper chart anyway, just stop tomorrow if you wish. And so we didn't have to set deadlines, it just became something that no longer is used. And then we began to dismantle the record room itself. There are 1,900 sites that you can see the record on in our hospital, plus we have a lot of wireless laptops, so we can make rounds on patients. We have ECGs, and we have the ability to pull the data for specific reports to improve performance. Clinical reminders, which links the reminder with action and with the documentation like I showed, are one of the major ways we have been able to increase our performance measures. And we can actually make reports to individual doctors. AA, BB, CC are all individual doctors, and you can see that, like DD has greatly improved his performance after having seen that he was very low in comparison with his compatriots. Just looking at the people to the right and left, he doesn't have to know their names, but he has to know that they can do a whole lot better than he, and he will compete. Doctors do compete very vigorously, and they try to not be last in line. The highest quality care in patients, VA measured broadly, was predominantly in those groups where we are establishing performance measure, but also in other measures as well by this article. And this is a listing of the measures in the year 2003 in the VA, in Medicare, and the best non-VA or Medicare performance measures. All measures we were the highest in at this point in time. I suspect that will change. Data retrieval, know the database, create automatic reports. We can improve compliance with computer entry that way, but also improve patient care. This is an interesting set of statistics, 1998 to 2004. The green line are those patients, the percentage of those patients previously with high blood pressure who returned to normal. And you can see that over time, that has greatly improved. And as a matter of fact, in the year 2005, we're up to 70%. I would not thought that possible when we were measuring it at 30 and 40%. But in this instance, notice that I am using all 13,000 patients who have had previously elevated pressures in my hospital. I'm not using just a sample, I'm using the total population. And of the patients who remained 160 over 100 with high blood pressure, it went from 28% down to 10%, and now it's well in the single digits. And you can see I can compare Baltimore with Martinsburg, with Washington, and each of us have increased, and we increase at separate levels. We also put a little competition here because Martinsburg, for some strange reason, being in West Virginia, Baltimore and Washington being intercity, maybe that's the reason, but Martinsburg always seems to be doing better than the two of us. But we use that to help as an incentive for improvement. Interestingly, in September of the year 2001, we saw the patients doing fairly well, and then the green got less and the red got more in January. And we worried that we were just letting down our guard and not doing as well, but we decided to look at the database and see if we could find an explanation. And sure enough, every September we did better, and every March we did worse, and every September we did better, and every March we did worse. Even though over time we had gone from 30% up into the 50s, we did it in a sinusoidal way. These are 6-month reports, and they show that patients are having higher blood pressures in the winter than in the summer. I hate to see what it might look like in Finland. But I would love to see what it looked like in Finland, as a matter of fact. I think it would be a very nice comparison because we don't know exactly why this is happening. If we use all of the blood pressures taken in the separate months, we get a similar sinusoidal curve. These dots now are representing every pressure taken in January or July and in their intervening months. If we use a different cut point, which is 160 over 100, we get the same sinusoidal curve. So there is a difference, and one wonders whether it's lightness and darkness, or whether it's coldness, or whether it's eating too much in the winter. We haven't figured that out. I've run that statistic, and it's a 3-pound weight gain on average in the winter versus the summer, and that's statistically significant, but it doesn't seem like enough to produce these results. Then we can pass to the provider the results of his patients and what percentage he's running at. We can also show him what kind of medications they're on. Diuretics, for instance, are missing in several of these patients and would be highly recommended, and we could actually get further improvement easily. This is LDLs, and you can see that in targeting those people that were in the high zone, we went from 68% to 83% in a little over 6 months. Then this is the current measure, which is to get it below 100%. The LDL report is quite similar. At the bottom in the middle, the lowest result, you can see that 90 is the result and 95, whereas 87 and 156 were the actual results. Those patients could be called up, the phone number is sitting on the right, and asked if they're still on their medications, and they might well improve. So we do create these master lists from the reminders, and we create central clinics to get all the patients whose LDL is greater than 100, whose hemoglobin A1C is greater than 9, or whose blood pressure is elevated, or whose mammography is overdue. We do a lot of targeted improvement. We had a beautiful example of how great the record is in this with Hurricane Katrina. 560 patients from the Gulfport Armed Forces Retirement Home were sent up to us at the Washington, D.C. Armed Forces Retirement Home, which happens to be right across the street from the VA. So we just took 16 laptops in 3 different buildings. Everywhere we could find internet, we could get on VPN access, which is what I use when I get on from home. Patients were immediately registered. Remote views were available on Katrina Web, which was the mail-out pharmacy's list of medications. And very soon, the Biloxi VA and the New Orleans VA were up and running, and we could see them with remote view. I could see an X-ray from Biloxi VA in my office easily. We ordered the medication, over 1,000 prescriptions in 3 days, and added the notes into Armed Forces Retirement Home walk-in clinic and a template, ordered consults and appointments. In summary, we use expert and non-expert advisors. We try to create local ownership by customizing templates with reminders and overall organization. We can actually customize the reminders as well. We package popular items, discharge summaries, labs, and images are popular, with unpopular order entry and notes. I actually implied that if they don't enter the orders, they won't see the discharge summaries, even though that's technologically not correct. It's probably in some ways correct. We want to maintain a hybrid status, in other words, having the notes and the record available so they don't feel threatened until about 60 or 70% of users are using it. That is a tipping point. Beyond that point, they will all start to use it, and you can't turn them back. We keep the software intuitive and user-friendly for rapid adoption by new providers, because we have interns and residents coming to our hospital all the time. They spend just about 3 or 4 hours in training, and within a couple of days they feel very comfortable with our system. And we use the record to provide real improvement in patient care. That may be the highest and most important incentive for doctors to use this, and for that matter, people and nations. You get an empty file room, and you get a president who is vowing to get a computerized record for the entire nation by the year 2014. This announcement was made inside a VA hospital, which he noted was not in the horse and buggy stage, but the rest of the nation possibly was. But as you well know, and we'll hear, a lot of the nation has moved forward quite a bit even since this announcement was made. Thank you very much.
Thank you, Dr. Fletcher. Could you stay a little bit there in case there are, I know that we have time pressure, but if there are questions, immediate questions, I'm ready to take a couple in. Otherwise, of course, he's available during lunchtime and later in the afternoon. Are there any immediate? Okay, the microphones are coming to you.
Dr. Fletcher, my name is Esa Soini. I'm the CEO of the Mylac Corporation of Finland. Thank you very much for your very interesting presentation. Now, VA had a very advanced program in the early 1980s called DHCP. And I was involved with bringing those tools to Finland when we built this hospital information system nationwide here in Finland. I was also involved with the project putting the DHCP tools and programs to the DoD hospitals called the CHC program. Now, you have done extremely much progress with the VISTA tools, now VISTA program. Now, my question is, could the history repeat itself? I mean, I know that the DoD, who is running a similar size of the healthcare organization than VA, is in trouble with the CHCS2. I mean, it doesn't make much sense to have in the United States two similar organizations developing different tools. So are there any plans for moving VISTA to CHCS? And could you also, is it still possible to use that same tools here in Finland?
First of all, it's clearly possible to use the same tools in Finland, if that's the way you wanted to go. This is public domain software and is available. And you have been using it for a long time, and I've been hunting for the people that did that, because I know a lot of that history, and you tracked very closely exactly what we were doing. Within a year of our implementation, you were doing very well, and I think that's why you have such a great edge to make a completely computerized system, because a lot of your doctors have been using this other system, which isn't as user-friendly as the systems you will likely develop in the near future. VISTA is a front for the old DHCP. In other words, the database has been the same, but now you have the Delphi front end, which I think you're probably aware of. And it makes it much more user-friendly. And we are going over, as I mentioned, to the Java-based system with a different database, but I have been told that the functionality will remain the same, and I think it probably should, at least in large part should remain the same. But I think it can only go better, and I know that seems to be sort of your plans as well. As far as the DoD goes, I think they made a mistake in the 80s, because they went out and bought a system that was actually provided by about 10 of our best programmers but our best programmers weren't able to keep it up to date, and there were just not enough of them, it seemed, so that their system never quite tracked as fast as our system. And I don't know that this, just a few days ago, we had some people at DoD looking very strongly at adopting the imaging system. That would be a smart thing to do, because it's, you shouldn't be developing things twice or thrice or so forth just for the heck of it. You should use other people's system if it's available to you, and clearly imaging is available to them and of course also to you.
Okay, go ahead. This is the last one. I'm sorry, we just have to continue, but
hello, I'm Ralf Eterbom from the Ministry of Social Affairs and Health in Finland. We are trying to draft legislation, as the Minister told, and what is one of the main concerns is how to deal with privacy issues and identity and access management in the system over networked social healthcare services. Could you briefly describe what kind of solutions you have? You have a big administration, you have more than 1,000 facilities connected. So what is your solution? Thank you.
Briefly, we are inside a firewall, and that's not breached. We can come into it on the internet with a virtual private network, VPN access, so that we can dial up from home and get into the system. And once we are in that private network, you do not see the traffic. And in addition, the access and verify code is very personal to each individual. And you have, in addition, a signature code for the prescriptions. It's a different code. It's changing. The verify code changes every 3 months and is a fairly long, complex one. And we just have not seen that problem so far. I mean, there might be some pretty smart people who might decide to make this one of their hobbies, so to speak, but our protection is quite good at the moment. And the most important thing about a patient is that the doctor who's caring for them vitally needs to know a lot of this information. So to keep it private from the next doctor could be lethal. And I think a lot of the patients understand that and thus want their information available in one fashion or another. But both the My Healthy Vet website and the other websites have a very high degree of security, and we have not had problems with identity being lost.
Thank you, Dr. Fletcher.